today. This is going to be interesting because we're trying to conduct our first Microsoft Teams panel discussion with people from all over the country. So bear with us if there's a few minor technical glitches. I'm delighted that there's lots of children joining the call. They might find some of the content a bit tricky to follow. So if you've got children, then perhaps consider switching to mute if that's not too much trouble, because otherwise it's a bit distracting. Thank you very much indeed. So I'm Simon Conroy. I'm a geriatrician based in Leicester and also work with the Frailty Networks, both Acute Frailty Network and the Specialised Clinical Frailty Network. And we've been asked to put this discussion on. So we've drawn together experts from across the country who I will introduce to you to try and just generate some thoughts and discussions about COVID and older people. We certainly don't have all the answers, so if you've come here for to get all the answers, we probably won't have them, but we'll do our very best to try and work through. So if you just go back one slide, Bettina, for me a second, just so I can introduce the panel. So Bettina's a geriatrician working at University College of London. I don't know whether we can see Bettina, but she's here. Oh no, you can't see Bettina because she's presenting her slide deck. And of course, London is one of the biggest centres as far as COVID is concerned. So we're looking forward to hearing how Bettina and her team have been getting on. Also joined by Jay Banerjee, who's an emergency physician, works with me in Leicester. Christina Fall's not joining us today, but Cassie Rowe-Haynes has joined us, who's a palliative care consultant working at our local hospice in Leicester. Danny Bryden is an intensivist who leads with the Intensive Care Society and has been heavily involved in putting together the NICE, the implementation guidance to accompany the NICE guidance on critical care decision making. So lots of experience from that area. And Chris Williams is a GP who is in Leicester. So just for those that have joined more recently, could you, if you haven't already, switch your headphones to mute and switch off your videos to avoid too much distraction as we go through. If you have got any questions or comments, if you write them in the screen, in the chat box on the side, and I'll try and get to them. So let's have a look. Is it possible? Yeah. Okay. I think we're all stable now. Now, Karen Harding, you've said we're all very quiet. Is there anybody having difficulty hearing us? Can you, Paula and Emma, are we all right for sound?
Yes, yeah. You sound okay, my end.
Okay, thanks. Okay, so I'm just going to quickly talk about what we're going to do, and then I'll hand over to Bettina. So, wow, COVID has been a really amazing experience and changed the way we work massively. I don't know what everybody's experience is across the country, but our routine business seems to have dropped off a cliff. And the focus is heavily on COVID and how it's impacting the way we work in health and social care, as well as our wider lives. So interesting times, as the phrase goes. So as I said at the beginning, the aim of this webinar is just to share experience. We can't promise to have all the answers, but we've got a group of people from across different specialities and different parts of the system, and hopefully we'll be able to generate some useful discussions. I think that's probably enough for me. I'm going to hand over to Bettina, who's going to sort of set the scene, and then we'll launch into a panel discussion. Thank you, Bettina.
Great. So thank you, Simon, for the introductions, and it's lovely to meet everybody virtually. What I'm going to do is to give a very brief overview of how COVID-19 presents. But of course, as Simon says, there's still lots of things that we still don't know very much about this condition. So I think it sounds to me similar to your experience, is that acute activity has massively dropped, and the people who are coming through our hospitals through ED and the ones that we see on AMU by and large falls into a number of groups, largely COVID related or suspected COVID conditions. So we tend to see the young males, we tend to see the people in their 60s, 70s with comorbidities, and of course we still see older people who may or may not be living with frailty. And this is not surprising because, as you know, the risk factors for severe COVID disease is male sex, people who are older, and people with comorbidities. The graph that I'm showing on the left-hand side comes from ISARIC, EXARIC is the International Severe Acute Respiratory and Emerging Infection Consortium, and this is a global clinical research network. They published a report quite recently based on about 12,000 cases of COVID-19. And these cases are submitted from lots of centres, over 200 of them around the world. The vast majority of sites are UK sites. So certainly our experience in London seems to be similar to what other people are seeing, largely in the UK, but also across the world as well. So you may be one of the 2 million people who have downloaded the symptom tracker from King's College, which aims to understand what are the most common presenting symptoms of people with COVID-19. And not surprisingly, fatigue, fevers, dry cough, loss of sense of smell, these are very commonly presenting features. But more specifically for older people, anecdotally, we seem to be seeing a lot of older people coming in with fever in isolation, so in the absence of other respiratory symptoms. And if an older person becomes fatigued, their function is really knocked off. So we've certainly seen people coming in with reduced mobility. And again, with high fevers, if they're not feeling very well, they're not eating, drinking very well, a lot of them also come in a bit dehydrated with postural hypotension, and we see falls as well. And again, anecdotally, although we know that diarrhea is one of the features of COVID-19, we seem to be seeing more of that in older people compared to the younger age group. Delirium is worth a mention because as geriatricians, I'm very used to seeing people with frailty presenting with delirium when they are unwell. And I suppose the delirium that we see in COVID-19 in this group is no different from somebody presenting with a very bad urosepsis. But I guess what is a bit surprising is that we're also seeing delirium in younger people and also in the pre-frail group as well. And certainly delirium is being considered as a separate entity in its own right within COVID-19. You know, perhaps the virus is causing some sort of viral encephalitis. And on brain imaging, we're seeing some people presenting with stroke as well, but it's very hard to differentiate as to whether people are presented with stroke because the severe spectrum of disease tends to occur in people with comorbidities like diabetes and like hypertension. Without doing population-based testing, it would be very difficult to work out what percentage of people with COVID-19 are truly asymptomatic. There has been a number of publications of different study sizes and different qualities. There has been a couple of reports from care homes in the US, population size about 90 in each care home. And when they went out to test care home residents, about 50% of the residents appears to be asymptomatic. But actually on following them through after a week's time, the vast majority actually do develop symptoms. So for most people who have COVID-19, this is a mild disease. They would feel unwell for about a week or so, and most people would then recover. We have seen a number of diabetics presenting with diabetic emergencies. So they literally come in collapsed state. It's very difficult to work out retrospectively when their symptoms actually start. But by the time they're presented, they're either in diabetic ketoacidosis or they're in hyperglycemic hyposmolar states. We tend to see the more severe symptoms, people deteriorating usually about day 7 to day 10. And the deterioration can be rather dramatic. They come in profoundly hypoxemic, and they've managed to slip into that degree of hypoxemia because they haven't developed any noticeable breathlessness as the oxygen saturation is dropping. So when they present with that degree of breathlessness and hypoxemia, it's sometimes difficult to differentiate, is this due to acute respiratory distress syndrome? Is it due to pulmonary embolism? And again, VTE is increasingly recognized within COVID-19 as a common problem. And when we scan, we do CTPAs on a lot of patients, we have also been picking up pulmonary embolism. What we haven't seen so much of is secondary pneumonia. And again, based on the Chinese data, there was a report of about 15% of COVID cases have secondary bacterial pneumonia based on typical symptoms or signs plus positive sputum culture results. When we do blood tests on these patients, what we very commonly find is lymphopenia, and the blood parameters are listed on the right-hand side of the graph are all associated with poor outcome and disease severity. And a typical chest X-ray finding is bilateral infiltration, but we've also seen people presenting with quite focal consolidation as well. And I'll certainly show you another X-ray when we go on to the case presentations. So how do these people do then? Well, certainly for older people, they don't do well if they've got a COVID-19 disease. There is a sharp rise in mortality in people who are age 70 and above. And it's not just because they don't get access to ITU. The ICNOG report was published a couple of weeks ago. The blue bars represent people with COVID-19. The orange is just there for comparison, showing non-COVID-19 viral pneumonias in previous years. And as you can see, for people who ended up on ICU with COVID-19, the older you are, the higher the risk of mortality. So in the age group 70 and above, we're talking about mortality of about 70%. And this is a really high figure compared to non-COVID-19 viral pneumonias that we've seen in previous years. So this is what I'm going to say about COVID-19. I've got a few case presentations. So Simon, I don't know whether at this point you want to open up the panel for discussions, whether there are any questions before I move on.
Yeah, I think this is a good time just to see what our panelists think of what you've had to say so far. And thank you for that really helpful introduction, Bettina. So panelists, if you've got queries, comments, additional points to add, do so now.
It's Danny here from ITU. I think, Bettina, that was really interesting, the variety of presentations in older people, because what we're seeing by the time they come to intensive care and are referred to intensive care is a fairly typical history, actually, of having been unwell for a week at home, then presenting to hospital, and it's almost a uniform type COVID history. So it's very interesting to hear that in the older age group, you've got a much greater variety of symptom presentations.
Mm. Okay. Thank you, Danny. So I think, Bettina, you've got some case presentations for us to have a look at and start asking questions about. So should we move on to those? And just before you start talking through that, just for those that have joined in the last few minutes, just a polite request, if you have joined recently, make sure you're muted and your video's off for the moment. And if you do have any queries or comments, just type them into the chat bar and we'll try and bring those into the discussion as we go through the cases. So Bettina, let's have a look at your first case.
Great. So I think this first case probably illustrates what Danny was commenting on about the atypical presentation. So this is actually the very first COVID-19 patient that I met, and this was in the beginning of March. So we have an 86-year-old lady who's got a history of dementia, possible Parkinson's disease, osteoporosis, for which she takes calcium. Now, she doesn't normally come to our hospital, and so at the time when I saw her, we didn't have any. Hello.
Whoever's just answered their phone, you need to mute, please, otherwise we'll hear your private conversation. Sorry, so carry on. Sorry, so at the time when we saw her, we actually don't have much background information about this lady apart from what was recorded in the A&E clerking from a history that was given by her relatives. So essentially for the past week, she hasn't been walking so well, she hasn't been eating or drinking so well. They took her to another hospital, she was seen, they checked her over, they didn't check her for COVID-19. There was a lot of anxiety around COVID-19 at the time, so this was something that the relatives were very keen to point out. And upon discharge, she had apparently been seen by a physiotherapist. She was able to walk with a frame, and so they discharged her. But unfortunately, following discharge, she continued to deteriorate. She kept falling over. There was mention of possible loss of consciousness, and she had become more confused. So the working diagnosis at the time of referral was possible UTI and postural hypotension. Examining her, she had a temperature. But from a hemodynamic and respiratory point of view, she is not doing bad at all, certainly not tachypneic, not hypoxemic. And I've listed here the investigations that were done in A&E. So urine dipsticks, for what it's worth, 1+ of nitrites. Venous blood gas was unremarkable. Her full blood count showed a lymphopenia. Renal function, we don't have a baseline, but her EGFR was 53. She certainly looked a bit dehydrated, and her chest X-ray was normal. Now, back then,
beginning of March, we were quite strict with regards to swabbing criteria. So certainly by any account, she does not meet the case definition at all. But COVID-19, just like a urinary tract infection in somebody presenting in an atypical way, is a clinical diagnosis. Certainly, if we were querying UTI, you have to exclude other conditions, and then empirically start passing on antibiotics whilst you wait for urine cultures. So I think whilst we were wondering about UTI, having excluded other conditions, we thought it's actually worth doing a COVID swab, and the swab came back as positive. So I was quite surprised about it at the time. So on talking to the family members, what we found out is that actually this lady, although she has got dementia, it's very mild dementia. She goes out, she goes to Ben Cross once a week to do her shopping. She uses public transport. She's independent, and she goes to day centre once a week. And on, retrospectively, pushing the family a bit, they did say that, well, perhaps she did have a mild cough about a week ago. So certainly, once I've got the collateral information, I changed the score on her clinical frailty scale from 4 to 6, which was what she was scored as initially. So in terms of her clinical...
Bettina, can I just interrupt you for a second there, if you don't mind? Because I think this is a really important point about the accuracy of the clinical frailty scale. And I just wonder perhaps if I could get Jay Banerjee to comment on that, because we've been, like many places, doing frailty scores in the emergency department. And Jay, would you just like to talk a bit about how easy it is to do frailty scores in the ED and how often you have to revise them?
So it is challenging, and I have to say, initially when we first started, we used to revise them a lot more. It is over the last, nearly 3 years coming up, it's definitely getting better. But even now, we tend to get it wrong at least once in one out of 10 times. I think it's interesting to see, as you mentioned, somebody had obviously marked this patient based on their acute frailty state, and then you revised it down to a 4. And a lot of the time, I don't think we are spending enough time and to really get details.
And the importance of this, of course, is particularly in relation to, if this lady is being considered for critical care escalation. So, Danny, what's your thoughts about the revised frailty score and how important that might be in this lady's story?
I think it's an interesting thing, because really for us in critical care, we're relying on the parent teams giving us the fullest picture that they possibly can of what that person could do before they became unwell. So being able to get more information is very helpful. I mean, for us, although the NICE guidance talks about as a trigger for some considerations and some discussions, they're kind of considerations and discussions, they're not absolutes. So when you get more information, I think it's really helpful then, because it helps us to make a better assessment of what's going on. We're not so bothered about the absolute number. It's more around the information you've got of what the person can do. Although, there is obviously evidence around somebody with a frailty score of 6 and somebody with frailty with a score of 4 having slightly different health outcomes in hospital.
Yeah, thank you. Sorry, Bettina, carry on.
Okay. So that's really useful to know, Danny, because I think once I got that collateral information, I realised that actually, she's not that bad. And on that basis, we discussed treatment and escalation plan. I couldn't discuss it with her because she was confused. I had a chat with her family, and I felt quite strongly that she should be considered for escalation, including to the intensive care units, if indicated. So because she turned out to be COVID positive, she was already in isolation. We ended up moving her from one side room to another. One of the things that's worth pointing out is that actually, in terms of getting the swab from her in the first place, it had been quite difficult because she was quite confused. So the first swab we weren't sure about, we had to get a second swab. So she stayed 2 days in a side room with no natural lights. We then moved her to a different side room. As I said, this was in the beginning of the epidemic, and so all the staff are quite nervous. Everybody has got full PPEs on, and her delirium actually got worse, and she had the hypoactive delirium. Her mobility went right down. She was needing 2 people to help transfer her. She wasn't eating, drinking well. We considered putting an NG tube in to improve her nutritional state, but she kept pulling it out. So although her COVID-19 disease was mild, the disease actually really affected her in a life-changing way. By the time we discharged her, 25 days later, she'd become bedbound and incontinent, and she ended up going to the rehab unit. And during the time when she was with us, actually by about, after about a week or so, her trajectory from a frailty recovery point of view wasn't looking so good. So on that basis, we actually talked to the family again and changed the treatment escalation plan from somebody who's for consideration for ITU to somebody who's for ward-based ceiling of care.
That's very sad, but it's an important lesson in there, isn't there? Because, of course, this frailty notion is very much dynamic, and you've demonstrated very clearly with this lady how her state changed over time. The delirium was a big factor in her changing sort of function and resilience and reserve. It does appear that the COVID is quite a deliriumogenic condition. I don't know whether others would like to comment on that, but we're certainly seeing a lot of mainly hypoactive delirium. I don't know whether there's any particular link to the different delirium phenotypes. The rest of the panel gone a bit quiet, but we'll keep going. There's a question here from Stuart Mackie-Thomas for you, Bettina, who's asking about length of stay. So I know you've just presented one patient so far, but do you have a feel for recovery? So Stuart's particularly interested in care home residents who are taking weeks to start eating or and recover in their recovery phase. And we might come to Chris Williams to talk about that as well in a short while. But first, Bettina.
Okay, so Stuart, I think I'll have to email you separately. The reason why I say that is because I've literally got a list of all the COVID patients that we have had since beginning of March. We have about 155 cases, and literally like this week, we're going to analyze the length of stay and whether it's related to them coming from care homes or whether they have package of care. Certainly, I would say in March, we had a lot of problems discharging people who are well enough to be discharged, largely because of the anxiety around the need for isolation, the need for PPEs in care homes and also in care providers, because of a number of issues. So one is the understanding of the condition, two is the availability of PPEs, and then three is the training of donning and doffing PPEs.
So Chris Williams, if you can give a comment, perhaps from the primary care perspective, you work in a care home. What are you seeing?
So I think thinking about when people are coming out of hospital, I'd echo what Bettina has just said about the amount of anxiety that there is amongst the care home community about taking people who have suspected or confirmed COVID infection back. I think in terms of discharge planning, one of the things our team has found in Leicestershire is that it's quite useful to have a kind of trusted, a trusted link person who the care homes will believe information about how the patient is post-discharge. I think it's probably fair to say that we're starting to get some residents back in care homes who are not at their previous baseline, and I think we need to remember that the recovery period probably extends well beyond the acute hospital stay. Two issues that have come up quite a lot in care homes. One is the PPE access and the PPE and staff understanding how to use the PPE. That message probably hasn't diffused as well in care homes as it has in acute hospitals. And I think there are also some anxieties about, well, what do we do if someone who is COVID positive starts sort of walking with purpose, wandering? And I think that, for a successful discharge, it would be a good idea to try and plan as much as possible.
Thank you, Chris. I've got a question that's come in from Michelle Platt, who works in the ambulance service in the East Midlands, who's asking about is it microemboli that might be influencing delirium? I don't know the answer to that, but just a question for Danny. Danny, are you doing any sort of transcranial monitoring or Dopplers or anything like that in ITU? Is that something you do routinely, or is that just a research tool?
The monitoring that we're doing at the moment is based on depth of sedation. So we are because a lot of patients that are ventilated are having to be very heavily paralysed, we have to make sure that they've got sufficient sedation on board. So we're using a form of processed EEG monitoring to look at their depth of sedation. And we know in our patient population anyway that we've got about 40-45% incidence of delirium even before this COVID started. So we are expecting to see a significant incidence of delirium in patients as they start to recover.
Simon, can I just make a comment?
Yeah.
So there has been a number of reports coming through. So one from China, which is a retrospective look at some of the presenting features in people with COVID-19. So certainly they have picked up people with altered level of consciousness. They've picked up people with seizures. They've also picked up people with myopathy as well, with elevated CK. Then there was a more kind of like prospective study, I think, coming out from New York. So that was from an intensive care unit. So upon waking people up from their sedation, they were reviewing people from a delirium point of view. And also in some cases were indicated these people got LPs, got MRIs. So there's been a number of findings, none of them particularly consistent because the numbers are still very, very low. So certainly there has been some cases of elevated proteins in spinal fluid. There has been some MRIs which showed leptomeningeal involvement. They've also picked up strokes as well, but as I said, because it's the more severe spectrum of disease that presents the hospital, the association with stroke may be related to underlying comorbidities like diabetes and like hypertension. But I think the evidence around this area is constantly evolving.
There's been a few comments about the delirium issue. It does seem that resonates and that people are seeing hypoactive delirium more frequently. And there's a really good point from Abigail Barkham, who's made the comment that we might be discharging people inappropriately to long-term care because they've still got a resolving delirium. I think that's a really important point. So technically delirium can last up to 6 months. It's very rare that it does so. So we shouldn't really be, we need to give people a good opportunity to recover to as much as possible before making decisions about placement, and community acute hospitals probably not the best place for people to recover from delirium, which means there's going to be considerable pressure on rehabilitation services, I suspect, which is, I guess, more of which soon. That's starting a discussion that's underway at the moment, isn't it?
Yeah.
Okay.
So I have a question for Chris and other primary care colleagues, if I may. And so this is actually about me looking back as I was doing the case presentation, because I think for me, the best chance that this lady had was probably in week 1, perhaps around the time when she presented to the first hospital, which is challenging because that was in the beginning of the epidemic. We don't know enough about the presentations. We were quite strict, as I said, about the criteria for swabbing. And so I can totally imagine this person being seen at home by a GP. Or by rapid response team, because we have got, an older person with dementia who's got reduced mobility. And I just wondered, a month on now, if this lady was seen in primary care, what would GPs be able to offer? Because I think that the two things about COVID-19 is one, actually, about all conditions is one, we have to get the diagnosis right. But the implication of this is that if she were to be supported adequately at home, with perhaps carers coming in encouraging her fluid intake, then we also need to get the infection control procedures right. And I don't know what's happening in primary care regarding accessing tests.
Chris, you're muted if you're trying to reply.
I'll have a go. I mean, it probably not as much has changed as we might think. I think the sort of testing of someone like this pre-admission, certainly where we are, isn't happening routinely. Unfortunately, one of the things that seems to be happening is that more of this work is being done by GPs over the telephone or over video conferencing. So I think the idea that this lady would have had a sort of much more kind of comprehensive assessment now in private care than she would have had a week ago. I'm honestly not sure. I think GPs, like all of us, are becoming more familiar with COVID and are keeping up with the recommendations. But I could envision a situation where this lady would be triaged. She would have, if she was visited, she would have her assessments checked, her observations checked. I suspect it wouldn't be very different. Probably wouldn't be swabbed. In terms of what's available in terms of supportive treatments in the community, I think that's probably quite variable. There may be places around the country where there's access to things like subcutaneous fluids or parenteral antibiotics in the community. Certainly, I've been able to access domiciliary oxygen for some of my care home residents, and there's no reason, that also available, to community older people as well. But I think it would be difficult. And the other thing that factors in is that, the sort of rapid response nursing services are feeling quite strained at the moment and a little certain about what they're meant to be doing. And that impact on the ability of services to mount a rapid response.
Thank you, Chris. Yeah. We didn't promise to have all the answers, so that's okay. Okay, shall we, Bettina, I wonder whether we'll move on to one of your other presentations. Yeah. And remembering we've got Cassie on from our end of life care service, so maybe we could discuss that, because that's a...
Well, I just add something. Sorry, I've been very quiet. Cassie from palliative care. I spoke about discharge.
It's hard to hear, Cassie.
Oh, apologies. So I've been very quiet to date, just while you've been talking about discharge, because our experience in the hospice so far is that 100% mortality rate for those with COVID. So we haven't got as far in our population of successfully discharging anybody who has been COVID positive to date, which is sad. Numbers are small. We're a 31-bedded hospice inpatient unit, and we've had 5 people die from COVID and no survivors as yet. So I haven't anything specifically to add around that discharge conversation at the moment, but more on symptom control maybe I can add in the next presentations. Yeah. Thank you.
Yeah. So I think Bettina will perhaps give you an opportunity to add your expertise. Thank you, Bettina.
Okay, so the next case is a 65-year-old gentleman who's very multimorbid. So he's got diabetes, hypertension, ischemic heart disease, irritable bowel syndrome, and I think because he's got quite a high BMI as well with some arthritis, he's pretty much wheelchair bound and he needs carers twice a day. So he's also admitted around, I think, beginning of March with chest pain, static troponin, dynamic ECG changes. So he was treated on the ACS protocol, and the cardiologist wanted to keep him in for a myocardial perfusion scan. Unfortunately, during his stay, another patient in his bay was diagnosed with COVID-19. So he was exposed. So we managed that whole bay in a cohorted area. And within a couple of days of him being exposed to the other patient, he himself started having fevers and coughing. But this is day 7 into his hospital admission with chest pain. Full blood count showed mainly lymphopenia, and we did a chest X-ray, which I don't know whether you can see, but in the left midsole, he's got focal area for consolidation. So I guess based on the timeline, based on the chest X-ray, he could very well have a hospital-acquired bacterial pneumonia. But in view of the lymphocyte count and the fact that he was exposed to a COVID-19 patient, we treated him as high risk. So that means isolation. And we send swab. Swab 1 was negative, so we send another swab, and that's also negative. Fortunately for him, he remained quite stable from a respiratory point of view. We cancelled his MPS, we started him on doxycycline for his presumed hospital-acquired pneumonia, and we discharged him with cardiology follow-up. But within the same day, he was readmitted with fevers and breathlessness. He wasn't that hypoxemic when he came back, slightly tachypneic respiratory rate of 23. Lymphocyte count by this point had got a bit better, and his chest X-ray looked quite similar. He continued to spike temperatures, and I've listed here are some of the tests that we routinely do now for COVID-19 patients, really trying to prognosticate. And actually, his bloods are not that bad. We still think that he's very likely to have COVID, so we kept sending more swabs off, and altogether he had 4 COVID swabs which were negative. So we changed his antibiotics from doxycycline to ciprofloxacin and then to ceftazidime. By day 5 of his readmission, which is day 9, his initial suspected COVID symptoms starting, he became increasingly hypoxic. So we ended up doing a CT chest scan, which showed a lot of ground glass shadowing, interstitial changes, especially in the peripheries. So certainly based on CT, he does have evidence of COVID disease. Unfortunately for him, he again continued to get worse. He became increasingly hypoxemic, and I think that's the main driver of him being delirious. He wasn't tolerating his oxygen. We've already had previous discussion with him that he's not for intubation, and he would have been a candidate for non-invasive ventilation, but he was really struggling a lot with his delirium, not tolerating us to put anything on. We ended up having to give him haloperidol, but that's a very difficult balance because the haloperidol can also cause him to get too drowsy and reduce his respiratory drive. And so all we ended up doing was really trying to manage the delirium, leave him on oxygen, not continue with non-invasive ventilation, and he died day 10 of his readmission.
Thank you. So a very sad story, but good opportunity perhaps to bring Cassie in to talk through symptom management. You've mentioned you had some patients in your hospice, Cassie, and perhaps you could give us a feel for what works and what doesn't work in terms of symptom management, what we need to be looking out for.
Yeah, lovely. I think I share with you some of the comments already that in the hospice, I suppose we're seeing is a very unpredictable disease in terms of its nature, kind of intensity of symptoms and the speed of kind of change. So it's very individualized, but there are some kind of common things that we have been supporting patients with. I think some patients seem to deteriorate very, very quickly, and others seem not too effective, but then ultimately things can escalate very and such as delirium and agitation being commonly seen in the acute setting. I think we were expecting kind of problems with delirium and agitation, but actually it's not been as prevalent as we were expecting, and certainly not hard to manage in terms of seemingly responding to usual doses of kind of haloperidol or midazolam for agitation. I suppose in our cohort, some kind of I suppose issues around understanding how much of what we're seeing relates to underlying disease, and agitation and delirium is a common symptom at end of life, not just in those with COVID. So trying to unpick what is COVID and what is part of a normal kind of end of life trajectory is not always easy. But I think it certainly hasn't been the huge problem we were expecting in terms of delirium and agitation. And usual doses, as I say, of kind of end-of-life medicines seem to have been fairly effective for our cohort who have died from COVID. The APM, the Association of Palliative Medicine, have got some very clear guidelines on symptom control at end of life for patients dying with COVID, and they've been replicated. Certainly our local guidance reflects those symptom control suggestions. It's worth looking at their website. They update their guidance regularly, but the symptom control guidance is accessible to look at the main symptoms around cough, breathlessness, agitation, delirium, and such like. So it's certainly worth having a look. But as I say, I think mostly we've managed to support those who are in the inpatient unit with adequate symptom control. I think my other area of work is out in the community, and I think there are certainly some challenges around supporting people in terms of end of life in the community, in terms of potentially timely access to symptom control in view of the speed at which some of these patients deteriorate, and accessing medicines is obviously something we've had to think very kind of carefully about. and there may be, again, data supporting some challenges around, patients' access to medicines if they are deteriorating rapidly. So there's all sorts of innovative ideas being considered around how we can access medicines quickly for that group that deteriorate rapidly in the community due to COVID, with breathlessness or agitation. I don't know if any of the other panelists, Chris, has anything to share around the community or symptom control specific.
I was just going to add that I think the one of the issues we've had both amongst community dwelling older people and in residential homes without nursing is that obviously there's a time lag in those settings between someone identifying the need for some symptom management towards the end of life and it actually being available. Pragmatically, what I've done, as well as prescribing the usual anticipatory medications, is try to prescribe oral options as well and encourage people to use the oral options whenever it's possible to do so. I don't know what Cassie about that from a palliative care perspective, but I get the feeling that, especially with if end of life community nursing services are stretched, that we should be thinking about that as prescribers potentially.
Yes, I would agree. I think the APM guidance considers subcutaneous kinds of cognitive medicines. It looks at alternative medications that can be given in different routes that, again, can be prescribed and accessed should, for example, supplies run out or there be issues around timely access. So it's certainly worth us considering prescribing alternative routes. I certainly haven't had to prescribe much in the way of alternative route because I think of the nature of our locality, but certainly for some of the colleagues joining us who maybe live in rural locations, in where access to medicines is an issue. I think I'm aware of, certainly in Cornwall, for example, they have a grab pack that is containing various non-subcutaneous medicines, oral medicine patches, sublingual tablets, preparations that are allowing relatives and carers or healthcare professionals to provide symptom using these kind of grab packs. Certainly we're thinking about such things locally as well.
Okay, thank you. I'm just conscious of time. It's now just approaching 10 to 2, so just for those that have joined in recent minutes, if you could mute and switch off videos, and any questions or comments you have, type them in. So I'm just going to reflect some of the comments that have been sent in by the attenders to the meeting, several of which focus on discharge. What are the arrangements for discharges? Who's following these patients up? So perhaps I could just start with Danny from critical care medicine. Danny, your discharge pathway within the hospital, what sort of things are you thinking about? Has anything changed in terms of how patients are stepped down from ITU to other parts of the hospital?
I think they have changed, and one of the things that has impacted has been, if you think of the general picture, critical care services have not been commissioned nationally by NHS England, only specialised critical care has. So unless your local CCG has identified a package around rehabilitation and support for follow-up clinics, most of the patients that come through critical care that are not on a pathway like MI or stroke, so this will be the COVID group, would go to the ward and they would receive whatever support they needed on the ward, pretty much on an ad hoc basis. There might be some ITU outreach or follow-up in the first few days, but then after that it just falls back to primary care and often the primary care services to pick it up. So that's the historical baseline. And if you the fact that the outreach nurses have now all been sucked into delivering critical care, we've got less there than we had before for this patient group. So I think it is a concern going forward that actually the critical care stay and the impact that it has on the person's health is going to have to be picked up by somebody because the structure wasn't there and we don't quite know who's going to be picking it up.
Okay, thank you. There's, I guess, the next issue. I mean, Ian Sturgis has also pointed out there's going to be a lot of hospital-associated deconditioning that existed before COVID, and that's going to continue to be a risk for this population. There's going to be a massive demand on rehabilitation services, and we haven't really got anybody on our panel from a rehab setting. But I am aware that there's some national guidance being drafted to think about different ways of providing rehabilitation at scale. I don't know, Danny, whether you're involved in that.
Well, certainly the faculty of intensive care medicine that I'm in, we are we were drafting guidance even before COVID started on life after critical illness, and that was to basically make the point that coming into critical care is a significant intervention that needs to be looked at in terms of a pathway. But obviously COVID has come along, and that group of patients are the immediate obvious group in which it will illustrate the fact that it's been quite patchy up and down the country, and it very much depends on your area what resources will be available for patients.
Yeah, so there's a couple of questions that have asked about whether acute hospital staff are supporting primary care and I guess community services more widely. I don't. Well, certainly in our locality, that's not happening. I don't know whether, Bettina, you've got any insights as to how that's evolving in London?
So we have been trying. So myself and a community respiratory consultant have been proactively reaching out to our primary care and also community team colleagues, saying that, well, the patients that we normally see coming to the hospital is no longer coming through. Are they with you? And actually, my understanding is that primary care is also very quiet. And likewise, when I contacted our rapid response team, they also seem to be quiet as well. So we just don't know where all our patients have disappeared to. So one of my greatest fears, of course, have these people just died in the community without access to healthcare services. So looking at ONS data for our local area, which is Camden, Islington, and Westminster, yes, there has been a higher number of deaths in March compared to last year. But, we're still talking about several hundred, so there should still be a lot of older people out there. I just don't know where they've gone.
Jay Banerjee from Emergency Medicine, what's it like in the ED and what are you doing differently? We haven't had much discussion about your world at the moment.
Well, in terms of the total volume, we have seen definitely a huge decrease of number of patients. Older people, yes, quite a lot of respiratory symptoms, quite a lot on the COVID side, but certainly far fewer, I have to say, in terms of from care homes with falls or from their own homes with other infections. That number has definitely come down. It is kind of hard to tell because we haven't looked at the data as to the total volume of older people and how much has been affected as a result of this, but a total number facing the same challenges. So if the frail older people, as Bettina has already spoken about it, are presenting with typical frailty syndromes, it's just a question of beginning to appreciate that the older person with the fall who's lying there quietly actually got a chest full of COVID, and that the challenge has been in the initial stages before we were particularly good with the PPE, but that seems to have slowly been kind of addressed over time.
Okay, thank you. Ian Surgis wanted to make a comment. I think I don't know, Ian, whether you can unmute and speak your mind. We'll just give you a second to get set up.
Simon, I'm here now.
You're here.
Yeah, Simon, I was typing it in, Simon.
Sorry.
It was just yes, fine. It was just an observation, part of our key lines of inquiry that across the Midlands region, when we've been discussing with systems around acute care of older people living with frailty, and that's COVID illness and non-COVID illness, is what's and people are obviously very busy at the moment. Is please keep an eye on getting some measurement of functional outcomes for these patients managed through either admission avoidance pathways or very early supported discharge pathways, because obviously that functional outcome and their overall outcomes will be very important to inform the new normal if during the recovery phase from COVID-19.
Okay, thank you, Ian. I think we're going to have to start to draw this to a close because it's 1:55 and we're supposed to finish at 2:00. So if there are any other final comments or questions, type them in now. Otherwise, I might just ask the panelists if they have any further points that they want to add. So if I just go round the panel, Bettina, any final thoughts, comments?
I think, as Ian said, I think we need to be proactively planning for recovery.
Yeah.
And I think the only way to do that is actually to be able to share the intelligence that we have, because the landscape is constantly changing. I just don't know what's out there. There is going to be a process of trying to proactively reach out to people who haven't been accessing services in the last month or so. So we need to look after that group. And as we discussed earlier on, we need to be looking out for the group who have recovered from COVID-19, the disease itself, but not from a functionality point of view.
Thank you. And then who's next? Jay, any summing up, final comments?
No, but there was a very interesting comment I've just picked up from the group about some people declining to accept support due to fear of COVID being brought into the home via support workers.
Oh yes.
And that is quite interesting, because we have actually seen that when we're trying to discharge people from the emergency department and suggesting package of care, we have had refusals.
Thank you. Danny, any final comments?
No, I don't think so. I think the discussion on the rehabilitation and planning and outcomes is really interesting for us in critical care, because it's definitely going to be an issue. So we definitely need more links between critical care and primary care.
Cassie?
I think just something we maybe haven't touched on as part of that recovery is going to be the huge need for bereavement services as well, for patients that maybe haven't had the good death, in inverted commas, that their loved ones may have wished for. So with visiting restricted in the hospice and in various settings, actually I think there's going to be a huge ask of bereavement services, and that's something that's going to be huge and something we need to think about.
Thank you. Yeah. And Chris, any final thoughts?
The only thing from me is, I think, echoing what Ian was saying a few minutes ago, that what we're doing now is going to shape the new normal. And I've found some of the things that have been going on in terms of the way that, you know, we're working in primary care with our colleagues in hospital to be quite refreshing. You know, in very difficult circumstances, but it's been really nice to be part of a system that feels in many ways like it's pulling together. And I think that might be a little bit of a silver lining that we can build on for the future.
Well, what a nice message to end on. If only this whole system approach and greater focus on older people could be our new normal, then maybe it's not all bad. Thank you to all our panelists. Thank you to those that joined. I think this has been recorded, so it will be available to you, and we'll try and get PDFs of the slides available, sent